Welcome to This Explainer. Today, we're diving into what is honestly one of the most incredible medical breakthroughs in human history, the heart-lung machine. Think about it. It's a piece of technology that literally lets us pause human life, fix the body's central engine, and then just start it right back up again. It's this fascinating intersection where biology meets engineering, and we are going to break down exactly how it all works.
To really wrap our heads around this complex topic, we're going to tackle it in 5 distinct sections: the untouchable heart, anatomy of the machine, the bypass procedure, the multidisciplinary team, and finally, risks and complications.
All right, let's start with Section 1, the untouchable heart. This was a historical challenge that stumped doctors and surgeons for centuries.
You see, for the longest time, the answer to a really profound question, can we operate on human hearts without causing mortality, was just a definitive, hard no. Early heart surgeries were incredibly limited. Surgeons could only address conditions that were deemed safe enough to fix without stopping the heart. We're talking minor tears of the pericardium or extracardiac issues like coarctation of the aorta. The heart was simply moving way too much and bleeding way too heavily to even attempt intricate internal repairs.
Well, the revolutionary solution to this massive problem was cardiopulmonary bypass, or CPB for short. Basically, it's a technology that completely bypasses the body's central engine. It temporarily replaces the function of both the heart and the lungs. And by doing this, it gives surgeons a bloodless, entirely motionless surgical field. This single invention opened the door to intricate procedures that, honestly, were previously thought to be absolute impossibilities.
Now, the journey to getting this technology right didn't happen overnight. Interestingly, the fundamental concept of an oxygenator dates way, way back to the 17th century with Robert Hooke. But the modern era, that really kicks off in 1937 when a doctor named John Gibbon built the first conceptual heart-lung machine. Fast forward a bit, and after the very first mechanical takeover of heart and lung functions in 1951, which incredibly used a machine co-developed with General Motors, it was John Gibbon who finally pulled off the first successful open heart procedure on a human being on May 6, 1953.
And when you look at the evolution, the contrast is just staggering. On one side, you've got John Gibbon's bulky early machine from the mid-20th century. It was an amazing prototype, sure, but it was massive and highly experimental. And then you compare that to the highly sophisticated computerized cardiopulmonary bypass machines we see in modern operating rooms today. They're these sleek, heavily data-driven marvels of modern engineering.
Moving right along to Section 2, anatomy of the machine. Let's look inside the pump, open the hood of this mechanical marvel, and see exactly how it replicates our biology. To truly understand how this machine works, you just have to look at human physiology, because the equipment directly mirrors our own biology. The machine's oxygenator, it does exactly what our lungs do. It adds oxygen and removes carbon dioxide. The roller or centrifugal pump acts just like a human heart, physically pushing the blood throughout the system. And then there's the heater-cooler unit, which manages homeostasis by controlling the patient's body temperature. That temperature control is absolutely critical during these massive invasive surgeries. In the operating room, they usually just call it the pump, and it basically consists of 6 main parts. First, you have the cannulae, which are the tubes going directly into the patient. Then, there's a reservoir to hold the blood, the oxygenator we just talked about, the temperature control unit, a highly specialized filter to catch any dangerous particles or microscopic bubbles, and, of course, the pump itself. All of these essential components are seamlessly connected by this complex network of silicone or PVC tubes, which is known as the extracorporeal circuit. But here's where we hit a massive biological hurdle. You see, human blood naturally wants to clot the second it gets exposed to foreign materials, like PVC tubing, for example. So to solve this, every single inch of that internal tubing has to be coated in an anticoagulant, typically a drug called heparin. This coating is literally a lifesaver, preventing deadly clots from forming inside the machine while the patient's blood is circulating outside of their body. Okay, Section 3, the bypass procedure. Let's walk through this step by step. How do surgeons actually transition a living, breathing patient onto this artificial life support? Well, the overall flow of the procedure creates a perfect continuous loop. Dark, oxygen-poor blood is drained away from the right side of the heart through those specialized tubes we mentioned. It travels out to the heart-lung machine where it gets filtered, cooled, and oxygenated. Then the pump pushes that newly bright red, highly oxygenated blood right back into the patient's body, usually directly into the aorta. This entirely skips the heart chambers and the lungs. This whole transition is highly choreographed into 4 very precise steps.
Step 1. A cannula is placed in the right atrium or vena cava to withdraw the venous blood. Step 2. That blood gets routed to the machine. Step 3. It gets pumped back into the arterial system. And then Step 4, which is honestly the most dramatic part, a third tube flushes the actual heart muscle with a specialized potassium solution called cardioplegia. This solution literally stops the heart from beating entirely, giving the surgeon that perfectly motionless canvas they need to work on. Seeing this play out in reality is absolutely astonishing. Right there in the surgical field, you can clearly trace the dark bluish blood exiting through the cannula heading to the pump. And right alongside it, you can see the bright red, highly oxygenated blood returning to keep the patient's vital organs alive. This continuous loop is what safely buys the surgeon time to work directly on the still, motionless heart tissue right in the center of the chest. And once that complex surgical repair is complete, the whole process has to be very carefully reversed. The heart is once again fed with normal blood, which effectively washes out that potassium solution and allows the heart to just spontaneously start beating again. From there, the patient is slowly weaned off the heart-lung machine, the cannulas are removed, and that intense blood thinning from the heparin is rapidly reversed using a counteracting drug called protamine. Today, this highly orchestrated, seamless procedure is the absolute backbone for a huge variety of critical surgeries. It's the standard for coronary artery bypass grafts, or CABG procedures. It's used for valve repairs and replacements, fixing congenital septal defects in both children and adults, repairing massive aortic aneurysms, and, of course, it provides the vital time window needed to perform full heart transplants. Which brings us to Section 4, the multidisciplinary team. The human element. Because a machine this complex, with a procedure this incredibly delicate, is absolutely nothing without the human experts running it. At the core of the operating room is a trinity of highly specialized experts. You've got the cardiac surgeon, who oversees the actual surgical intervention and the physical cannulation of the heart. Then there's the anesthesiologist, who meticulously monitors the patient's hemodynamics and vital signs. But the true pilot of the heart-lung machine is the cardiovascular perfusionist. This person is solely dedicated to assembling the specific circuit for that patient's needs and managing the blood flow and oxygenation for every single second the patient is on bypass. But, this core trinity is backed by a massive supporting cast. We're talking scrub and circulating nurses ensuring a strictly sterile environment, biomedical engineers keeping the machines running flawlessly, pharmacists perfectly preparing complex drug cocktails, respiratory therapists managing the ventilator, and clinical pathologists running real-time lab work. Open heart surgery really is the ultimate medical team sport, requiring intense, unwavering coordination. Finally, Section 5, Risks and Complications, the clinical realities. Look, we've seen the absolute miracle of how this works, but we also have to acknowledge that bypassing human physiology carries some very severe clinical risks.
Despite being a life-saving procedure, taking a patient's entire blood volume and running it through plastic tubes can trigger dangerous complications. The major risks here include coagulopathy, which is a severe disruption of the blood's clotting factors that can lead to massive bleeding. There's also the risk of acute kidney injury from altered blood flow, intense systemic inflammatory responses from the blood interacting with the artificial machine, and serious neurological complications like strokes.
Thromboembolism is actually one of the most prominent concerns for the team. When blood is exposed to foreign substances and abnormal shear stress inside those artificial tubes, it naturally wants to clot. If a thrombus, or a clot, actually forms, it could obstruct the oxygenator or even the pump head. But worse, if that clot manages to get pumped back into the body, it can travel straight to the brain and cause a devastating ischemic stroke. Now, one of the most fascinating yet incredibly dangerous neurological risks is something known as Harlequin syndrome. This can happen during certain types of extracorporeal support when the blood flow is mismatched. Basically, a patient's upper body and brain might be receiving poorly oxygenated blood from their own struggling lungs, while their lower body is getting beautifully oxygenated blood from the machine. This drastic mismatch can lead to chronic cerebral hypoxia, essentially starving the brain of oxygen while the rest of the body is perfectly fine. All of this brings us directly to the frontier of this technology. Science is constantly pushing forward. We're seeing new innovations being developed like smart reactors, camouflage coating, which aim to reduce the thrombogenicity of the tubes. This would minimize the need for high-dose systemic blood thinners and ideally lower those complication rates. It really leaves us with a provocative question. As these surface coatings and technologies continue to advance, will we one day be able to perfectly replicate human biology and completely eliminate the risks of bypassing the human heart? It's a thrilling future to think about, for sure. Thank you so much for joining me on this explainer. I hope you learned something fascinating today.